Hello, this is Katie Carter, and this PowerPoint presentation is based on the education of ambulating our patients, and the overall goal is to incite a change in current practice and to persuade staff nurses to ambulate patients who have been released through physician's orders a minimum of once per shift. Cognitive objectives. Following this PowerPoint presentation, nursing staff will be able to list at least 5 reasons why ambulation is important, list at least 5 consequences of immobility, identify 3 reasons why additional assistance would be needed to safely ambulate a client, identify where providers' orders can be found in a chart listing any limitations and/or restrictions to mobility, and list 10 assurances to safe ambulation prior to getting a patient up. A knowledge check will be done at the end of this PowerPoint presentation with a post-test and also a question and answer session. There will be opportunity for questions at the end. So let's start off with the importance of ambulation. It promotes circulation. So we want to prevent blood clot formation. We want to promote overall cardiac health. We want to promote lung health. We want to promote circulation of our gut, really all over our body. So, getting our patients up and moving them prevents blood clots. Increased gut motility. So one of the things about laying in the bed and not moving around as much is it can lead to constipation. So especially after an abdominal surgery or any type of surgery, what we want to do is we want to get our patient up and we want to move them around. It helps to release gas, which is often a complaint that a patient has after surgery, is that they just have so much gas. What are we told to do by the surgeons? Get them up, move them. So, and it also prevents urinary retention, and if we're preventing urinary retention, we're preventing urinary tract infections and other complications such as hydronephrosis and therefore kidney injury. So patient after surgery, typically we have like a 6-hour window where the patient needs to void after having anesthesia, and if they haven't voided, we then do a bladder scan, and depending on which the hospital policy is where you work, usually greater than 300 or 350 mLs requires an intervention. So we don't want to jump straight to using a Foley catheter. We want to get the patient up and move them around. We want to get them on the bedside commode. We don't want to just jump straight to an invasive procedure such as catheterization. Mobility is really the best option is for urinary retention. Also promotes circulation of the skin and therefore pressure ulcers. We don't want a pressure ulcer as a result of hospitalization, and we don't want that on our name, behind our name badge. So move your patient around, move them from side to side, get them up and moving so that we can promote circulation of their skin. Increases lung expansion, and if we're increasing lung expansion and we're promoting lung health, we're therefore preventing pneumonia. Also, maintenance of physical strength, joint health, and the prevention of contractures. Number one thing of hospitalization, it seems like everybody always goes to a rehab facility or they have to have home health PT. They're already coming in very weak and they're not feeling well. And then on top of that, we're maybe getting them up once per shift, and it's usually physical therapy who's doing it. If we do get them up, we might be getting them up to the bedside commode, but that's questionable given these new external catheters, which I feel are definitely overused and not for the convenience of the patient, but ultimately for our convenience, especially on the overnight shift. We need to get them up. We need to move them. We need to put them on the bedside commode at the very least. That's 5 steps to the bedside commode. Move the bedside commode out a little bit further, and we have 10 steps to 10 steps back from the bedside commode. And that's what we need to be doing for our patients. They're not using these PureWicks at home or these male wicks at home. They're getting up and they're going to the bathroom. They need to be doing the same thing in the hospital so that we can prevent them from being deconditioned and having to go into rehab facilities. Also, feelings of self-confidence and retention of psychosocial well-being and self-worth. It's so important. Not only promoting overall health on the outside, the physical side of the patient, but also the emotional and the spiritual side of the patient. Consequences of immobility. So just reverse everything that we just said. So loss of independent ambulation, which leads to lack of confidence and or psychosocial well-being, feelings of low self-worth, and also pain. Laying in the bed is painful. A lot of times I hear patients complaining that their back hurts. It's from laying down in the bed all day long and all night long. Also, physical deconditioning and debility, prolonged hospital stays, higher readmission rates due to complications. And we all know that if a patient is readmitted within that 30-day window, the hospital eats that cost, and it's really a demerit on us. But ultimately, aside from readmission rates, you know, the patient wants to go home. They want to stay home. They don't want to have to keep coming back to the hospital because now they're going into one complication after another. So we really need to do our best to prevent that. Increased number of falls. Maybe they haven't fallen in the hospital because they're deconditioned, but maybe they've gone home and now they're falling at home and they're coming back. And the last thing that we want is for them to hit their head. Increased risk for blood clots, so which we know can lead to stroke, pulmonary embolus, deep vein thrombosis, and or heart attack. Constipation and ileus. I see a lot of ileus happen, especially after surgery, and that could potentially be prevented if we are getting our patients up early after surgery and ambulating them. Inability to urinate on their own and or urinary retention, which again, infections, kidney injuries. Pressure ulcer formation and contractures, low lung expansion, and therefore pneumonia. So as far as locating providers' orders, one of the first things I always do is I look at my orders. That's my number one go-to when I come in. Under your orders tab, you should always look for any restrictions that the patient may have. Usually the order can be found under nursing communication. The order may read bed rest, non-weight bearing on the right or left leg, or no weight bearing on either arm, partial weight bearing of an extremity, or toe touch only, etc. But the providers may want the nurse to assess for orthostatic hypotension prior to ambulating as well. You want to look for any orders that might indicate a vibration on any other assistive device, such as a walker or cane. And always read your notes from therapy and the providers prior to ambulating a patient. You want to check your orders more than once. Check and recheck, and always make sure that you don't have any new orders. And ensure you identify the patient and gain consent from them. As far as our psychomotor objective, at the end of this teaching session, the learner will be able to demonstrate safely assisting a stable patient to ambulate according to caregiverology.com. So when is help needed? So you should have a second person to assist you with the patient if the following applies. If a patient is weak or dizzy, a second staff member can follow behind the patient with the wheelchair. Before that, though, if a patient complains of weakness, you need to do your orthostatic vital signs. If there's a drop greater than 30 from any postural change, you probably don't want to get that patient up. You want to call the doctor and let them know that they're positive for orthostatics. Anytime you're feeling uncertain, a wheelchair can always be readily available behind the patient, wheeled by that second staff member. And this is a security blanket and will boost your confidence and provide feelings of safety for you and the patient. Also, anytime you have multiple pieces of medical equipment, maybe the patient has a chest tube, somebody needs to carry the canister, or they're on oxygen and you need to wheel the mobile oxygen behind them. Maybe they have an IV pole that the patient can't push, etc. You want to read your notes from physical therapy prior to beginning ambulation because they may indicate if one or two people are needed. And therapy notes should always indicate which type of assistive device is needed for safe ambulation as well. If the patient has a weaker side, maybe the patient's had a stroke with residual deficits, one should stand on the strong side, typically the nurse. Well, the nurse should be on the strong side, and maybe the patient care tech is on the weaker side. There are some. Okay, so how to safely ambulate a patient. The first thing that we want to do is ensure that we have an order to ambulate the patient, that there aren't any restrictions, which we've just talked about that. You want to ensure that you have washed your hands, knocked on the door, identified the patient, and gained consent from them. You want to ensure that the patient has non-skid footwear in place, and you want to use a gait belt. If you don't have a gait belt, you can typically get that from therapy or your manager, or they're on Amazon for about $10. I feel that every nurse should really have a gait belt. You want to assist the patient to a sitting position. Use a second person if needed. Begin by placing your arm behind the patient's shoulders using proper body mechanics. Feet spread apart, knees bent, and you want to ensure that the height of the bed is appropriate. Use your arm to place beneath the patient's knees, grasping onto the patient's knee farthest away. You want to pivot the patient sideways, swinging their legs over the side of the bed. The patient should sit in this position a minimum of 5 to 10 seconds. An inquiry should be made as to any dizziness or lightheadedness. The patient should be asked about strength. Use assistive devices if needed, such as a cane, walker, or gait belt. With both feet spread apart, you want to position one of your feet in front of the patient's feet and at a right angle to them. Your other foot should be in line with the patient's body and perpendicular to the bed or the chair. The patient should be asked to stand on the count of 3. Using a gait belt or placing your arm beneath the patient's arm, assist him or her to stand. Once standing, the patient should stay put and inquiry made again on dizziness, lightheadedness, or weakness. Remind the patient to stand up straight and look forward when walking. Have the patient take 10 steps at a minimum and use a wheelchair to follow behind the patient if hesitant. If walking beside the patient, you should be slightly behind them and to the side of them. And always hold on to the gait belt. Another staff member can wheel the chair behind the patient. I'm going to keep reiterating that because if we ever feel hesitant or unsure, this is really our safety blanket. You want to reassess how the patient is doing as you're ambulating them and continue to ambulate them, or we can turn the patient around if able and have them walk back to the starting point. So sometimes no matter what we do, a patient still falls. And in the instance that a patient should fall, you should not try and break their fall because you don't want to hurt yourself and you don't want to potentially hurt the patient. Rather, what you should do is you should stand behind the patient and maintain a wide base of support. And what you want to do is you want to ease the patient down your bent leg onto the bottom. You want to hold on to the gait belt as you do this and always, always ensure that their head is protected. An assessment should be done and the doctor should be called as well as the supervisor. Should not get the patient up until the doctor has come and seen the patient and the supervisor has seen the patient. And that might vary depending on your facility and what their protocol is. A mechanical lift should then be used to assist the patient back to bed. You want to follow your protocol at the institution you work at as far as the incident report is concerned. Undoubtedly, one will need to be completed. And this is an image showing how to ease the patient down so that the fall is safe for you and for the patient. And this is where I got the image from. Okay, so we will now do a return demonstration. I've already gained consent from a patient, and we're either going to use the patient or another staff member. We're going to make sure we get our proper footwear and all of our devices that we're going to need and a gait belt. And we're just going to ask the patient to take 10 steps. And if they're able to take 10 steps back, we will assist them to take 10 steps back to the bed or chair. And we're going to allot about 15 minutes for this for 10 to 20 steps. So at this time, I really just want to allot some time to talk about any concerns that anyone might have as far as determining whether or not ambulation is safe for their client. And then I also want to explore any concerns that you all might have regarding barriers to ambulating your assigned clients. And upon completion, I want everyone to be able to encourage others to ambulate their patients once per shift via role modeling. Again, I just want to summarize everyone's concerns. I want to explore feelings through discussion. I want to allow opportunity for questions. I want to clarify anything that needs clarification. I'm going to offer you all active listening and understanding. as I do understand a lot of the barriers. Probably, everything that you all are going to discuss with me, I've already identified as a potential barrier because I am also a staff level nurse, um, and I know what it is. But I also know that there are many opportunities that even me, myself, I could be ambulating my clients. Um, and I'm not, and typically the patient just doesn't feel well and maybe they don't want to ambulate. And what we can do is we can just say, okay, well, let's pick a time that's good for you, and I'll come back at that time, and we'll go ahead and walk them. And then what I want to do at the end, after we've voiced our concerns and all of the barriers that we've identified, is I want to allot an opportunity for us all to sit and brainstorm what we can do to improve our compliance with the goal and increase our comfort level with ambulating our clients.